In the lobby.
Let's just to allow a couple minutes for our attendees to join us. Welcome everyone to our 311th gathering of the Right Care University of Best Practices. I have as my background shot today a very special group of our team members that went with us to the Centers for Disease Control for launching the CDC's Hypertension Roundtable in September 2019. So the 3-year anniversary of launching that work, and we are just so lucky to be a strong, vibrant team even after the pandemic, and so appreciate all of you being with us. I just want to say that we prefer that you use the Q&A function and not the chat function. Very happy to see one of our co-founders, Scott Flynn from Blue Shield, joining us. Thank you so much, Dr. Flynn, for your support of the Right Care Initiative over the years. I think you recognize your picture behind me, and I really appreciate that you've been supporting the Right Care Initiative since about 2011. So thank you. And thank you to all of our many partners in this growing collaborative, including our mothership, UC Berkeley School of Public Health Center for Health Outcomes and Innovation Research, the California Department of Public Health, Blue Shield of California, UCSF, Travis Air Force Base. I'd have to say thank you also to the military for lending us Joe Sky as our vice chair. So thank you also to Katrina Taylor, who's with us, and maybe we could just do a screenshot when we have everybody, the team together. So 1, 2, 3. Thank you so much. So let's go to here we've got Dr. Desai. He just joined so we could do a photo. Dr. Desai, can we get you back on? Here we go. And let's see, I'm just moving people around a little bit. 1, 2, 3. Thank you so much. This is all about people. The way you change the world for the better is through collaboration. I'm a big believer, and that's what the Right Care Initiative is all about. And that's why my background shot is all about the people that I work with. It's been an amazing 15-year journey, and it wouldn't be possible without all of our wonderful supporters and collaborators, including our biotech partners over the years who've been helping us to carry on this work. And thank you especially Dr. Katrina Taylor for working with us so closely on the data that undergirds this project from the California Department of Public Health. Next slide, please. Everybody knows me. Next slide, please. I just want to highlight the importance. A lot of people don't understand this CDC Wonder data, which has recently become available during the COVID pandemic, showing that already by age 35 to 44, it's cardiovascular disease that is killing more women than breast cancer and cervical cancer combined. And I see one of our leaders is trying to come in to this call right now. Dr. Arevalo just called. If Jenny, would you please send him a link to this meeting, Dr. Jose Arevalo from Sutter Independent Practice Association. So I just like to highlight at the beginning of our meeting that already in these young parenting years of age 35 to 44, for both men and women, cardiovascular disease is killing more people than the standard cancers that they are screened for. So I want to encourage early screening for cardiovascular disease and to really educate the patients about this being their greatest risk. And with that, next slide, please. So we drive this project through accountability to data, accountability for performance on key metrics, specifically blood pressure, blood sugar, cholesterol. Bill Baumer has done an amazing job as our chairman leading our Sacramento group. And as you can see, Sacramento has the most consistent high performance in the state. Compared to the other regions, there's more variability. Next slide, please. So what we do with that data is we meet with medical groups and we say, these are proven best practices for raising your performance. And it's everything from physician activation to patient activation to team-based care to the use of protocols. And what we in the Right Care Initiative do is try to raise awareness about the best practices like those that we're going to learn about today. Next slide, please. I'm going to turn the meeting over to our chairman, Bill Baumer now, very famous cardiologist in the state of California who's trained many of the cardiologists in our state. And he will go over the agenda. And I will just say that not only is he a famous cardiologist leading the California Right Care Initiative University Best Practices, but he's also now leading the statewide update of the comprehensive plan for action to reduce heart attacks, strokes in the state of California. So thank you for leading all this amazing public work. Dr. Baumer, take it away. Let's have you go through the agenda first and then on to your slides.
Today we have, thank you, and can everyone see my slide? Today we have a very fascinating program, and we're going to start out with a little bit of an introduction of what hypertrophic heart disease is, and then we have two sophisticated, literally users of individuals of this disease process. Dr. Jeff Southard is going to talk to us about TAVR, or aortic valve replacement with intervention, and Dr. Melinda Desai is going to talk to us. I'll introduce them in a minute. First, I wanted to, let's say, introduce the topic. The topic is hypertrophic heart disease. And, you know, we would always think, hey, if you have a thicker heart muscle, it should be a stronger heart. Well, that to some extent is true. And that's what training does in many sports. But there is a problem, there is a position where you get too much hypertrophy, and that hypertrophy leads to problems that you have. And some of the problems that are seen with hypertrophic heart disease are shown here. If you have significant hypertrophy, that increases your risk of sudden death, heart failure, and heart attack by a factor of 6 to 8. So it's a significant increase for that. Right Care has focused in the past on the other causes of hypertrophy, being hypertension, obesity, and age. And certainly, we have previously discussed taking the importance, as Hattie mentioned earlier, of antihypertensive therapy to reduce hypertrophy, anti-obesity therapy to reduce hypertrophy. But today, we're going to move a little bit beyond that and study two other causes of hypertrophy. One would be related to left ventricular obstruction. So the anti-obstruction therapies to reduce hypertrophy will potentially reduce the morbidity and mortality associated with excess hypertrophy as we have it. So to summarize that, we can see that left ventricular hypertrophy, again, has an increased risk of 6 to 8-fold times risk of cardiac events. So significant. We certainly can work on reducing hypertension, and we have other ways to reduce aortic and subaortic obstruction. Our treatments for hypertension are obviously medicines. For aortic stenosis, medical therapy has not been that successful. We've tried anti-inflammatory agents, lipid medications, and valvuloplasty, which offers perhaps a temporary reprieve from aortic stenosis. But the only real therapy that has been proven is valve replacement, and we'll talk about that today. For hypertrophic cardiomyopathy, we started out with drugs used for other therapies like hypertension, that is beta blockers and calcium blockers, which were used, and disopyramide is an antiarrhythmic agent originally, which has been used in hypertrophic obstructive cardiomyopathy. Today we have, and we're going to discuss, a fascinating new class of drugs called myosin inhibitors that actually work right on the mechanism of preventing excess myosin linkage to the actin in the muscle, and may actually have a process or a part in preventing the development of some of the disease processes. For those that don't respond to medicine, we have septal myectomy or ablation, and we have mitral valve replacement. Those are surgical or interventional procedures which carry a high risk. For those who have not looked at outflow tract obstruction, I've shown them here in a diagram. The two of them, supravalvular narrowing, which you see on the top, and just below the valve is subvalvular stenosis. Those are mostly congenital abnormalities, and we see those in our pediatric populations. The ones we see in our adult patients are the valvular stenosis that you see at the valve level, shown there, and the development, which usually occurs after puberty, of hypertrophic cardiomyopathy, leading to obstruction right there in the ventricle as well. So those are the causes of left ventricular obstruction, which contribute to high pressure gradients and additional hypertrophy of the ventricle. For the aortic valve, normal is seen on the left, and all of the other valves are aortic stenosis, either congenital or acquired disease. And you can see that there's very little room in those slides to the right for blood to actually exit the heart. The calcified nodules that are sitting there are very stiff, inflexible, and do not allow that valve to widely open. So it leads to an obstruction to outflow for those valves. And for the patient who has aortic stenosis, who develops it, they frequently tolerate it fairly well early on in their lifetime. And the reason is, as the valve stenosis gets progressively worse, the ventricle hypertrophies and can generate a higher pressure gradient and get blood across the outflow tract obstruction. Well, that works for a while until the left ventricular hypertrophy starts to fail. And when it fails, the patient becomes symptomatic quite quickly at that point in time. And once you have a failing ventricle and severe stenosis of the aorta, you are in trouble, as shown on the right, if you develop angina, syncope, or heart failure as the typical symptoms of severe aortic stenosis. Your survival is literally from 2 to 5 years at that point in time, and you rapidly decline, as shown on the upper graph, for survival at that time, related to two things. One is the worsening obstruction, as well as myocardial ischemia, because remember, the myocardium is being fed by a low pressure system distal to the valve, and you suffer myocardial ischemia almost as if you had coronary artery disease, but now you have a severe outflow burden to counter at the same time. Now, if we look at the trials that have been done for patients for medical therapy for aortic stenosis versus surgical intervention, what you see is the line on the top in red marks an area where patients get worse quickly, and that is a valve area of 1 centimeter square. So as soon as your aortic valve goes down to less than a centimeter in area, you quickly see that medical therapy doesn't work. And in fact, in the trials, medical therapy was associated with a 2 to 4-fold increase in mortality compared to replacement of the aortic valve, whether you had a normal ejection fraction or not. So once you develop symptoms with aortic stenosis, it's a rapid downhill course and something needs to be done. And the only thing that has been successful so far is not medical therapy of any kind, but is a surgical or interventional replacement of the valve. And that is evident here, where you see for the state of California, all of the valve procedures that you see are shown on a scale with a gradual increase as we go from left to right on the top bar graphs of increasing procedures for valve surgery in California. But if we look at the graph on the bottom, you see one graph in pink going from literally 0 at the middle of the scale to the highest number as we go to the right. And those dots in pink are literally the procedures of TAVR or TAVI, that is transcutaneous aortic valve interventions or replacements in those patients. And you can see it is now in the state of California, as well as the rest of the US, the most predominant valve procedure done in the US and certainly in California as well. And literally far outnumbers the other valvular procedures that we have. I mentioned earlier that medical therapy of aortic stenosis has not been successful at all in the patient who is severely symptomatic. For a patient who is not symptomatic, we still may slightly monitor and slightly treat their blood pressure if they have hypertension as well. But clearly we have no medical therapy today for aortic stenosis. What we have for the patient who is symptomatic is an offering of 3 options for the patient, and they vary depending on the goals of the patient. One is surgical aortic valve replacement on the left, which can be done, but is approximately a week in the hospital. It's a big operative procedure. It does work, successful in most cases, but there is a fair amount of morbidity associated with a very large surgical procedure. The one in the middle is TAVI, which is a transcutaneous aortic valve intervention that replaces the aortic valve in most situations with a catheter procedure that can be done through just a catheter insertion in the femoral artery in the leg, and that can then be placed quickly in a patient who is awake. And the patients for this can be wide awake talking to you as you're replacing the valve. You have them hold their breath for 10 seconds, expand the valve, then you say breathe, and then you tell them, hey, you have a new aortic valve replacement at this point in time, and you may go home later today or tomorrow if all things are going well. And you can show that life has been prolonged in those individuals and symptoms have been relieved. And Dr. Southard will discuss that in a minute. The last thing, though, that we have to consider is there are some patients, because this affects aortic stenosis, older patients that are so frail, so old, or have such comorbid disease that a decision might be made not to do any procedure on those individuals because they're not enjoying the quality of life that they have. And even with a valve replacement, that's not going to change perhaps their neurologic or their functional class in many situations that is limited by other comorbid disease. So there are still cases where we wouldn't do it. But the problem today is literally the majority of patients with aortic stenosis right now are getting palliative care, meaning they get no interventional therapy and they literally die of a disease that could be possibly alleviated significantly in that patient population. And that has caused a recent opinion paper shown here that we are undertreating aortic stenosis at this point in time. And today we wanted to discuss that and present that so that this hopefully does not be continued in the state of California. At the bottom in red, you see that in the Journal of the American College of Cardiology, they presented the scenario in patients with symptomatic aortic stenosis who were undertreated, and literally 50% of those individuals who had indications and would have potentially benefited from aortic valve replacement never got it. So we literally are only treating less than 50% of our patients who could significantly benefit from that disease. And that's why we're discussing today this. The paper that is shown in red in that presentation was from the Massachusetts General Hospital, which we usually regard as one of our top hospitals in the United States and clearly in the world today. And if we're undertreating them at one of our premier hospitals in the United States, the concern is we could be doing that even to a greater extent in other hospitals. To discuss that today, I'm going to be introducing Dr. Jeff Southard, who is Associate Clinical Professor at UC Davis in cardiovascular medicine, and literally specializes not only in interventional cardiology, but in TAVR, and has done an outstanding job in that. And Dr. Southard has a long CV, and rather than go into that and all of his awards and everything else, I thought I would mention just two things. Jeff came to me as a chief fellow from Georgetown, as a fellow candidate. I met him off track at the time because he could not come out at the regular time. Met with him, talked with him. I was so impressed. I put him down on the match list at that point in time without having him actually interview or go through the formal process, because he struck me as an outstanding individual. And you can see on the left that has proved true. In his ratings, he is 5.0 out of a total of 5. Everyone who meets Dr. Southard goes away with a positive impression of him. And I'm delighted to introduce Dr. Southard at this time to discuss TAVR. And I will stop share content.
Thanks, Dr. Bomber. Very kind. I'll pull up mine here once you're done.
All right, we can see yours.
All right, very good. And everyone can still hear me, it sounds like.
Yes.
All right, well, I'll get going. Dr. Bomber's absolutely right. I got extremely lucky that he was willing to see me. I happened to be out in California from the East Coast, and it was an off interview day, and he decided to meet me and interview me personally, and I was very lucky. He took me to the 14th floor of the hospital. He had me look out the window, and he said, "You could have this view every day." Now, just so you know, I've been here now about 19, 20 years, and I've never been back to the 14th floor or looked out that window. But, you know, he knew what he was doing, I can tell you that. So it's been an amazing journey here at UC Davis. And he's kind enough to ask me to speak to you about transcatheter aortic valve intervention, which I've been lucky enough to be a part of here at UC Davis since its inception. I wanted to teach you and update you about aortic valve stenosis, how we got to this aortic valve implantation. And I will do that in a quick way as to not take time from our other speakers. On the initial slide are people that have been involved very importantly in the history of aortic valve intervention, and we'll get to them shortly. I have a few disclosures that I do work with aortic valves. I work with companies who make valves. There's only a few approved in the United States, and I work with all of them based on research and developing new valve strategies. So remember, we've heard a little bit about aortic valve stenosis and the most common types of aortic valve disease. Again, bicuspid patients born with a congenital abnormal valve, patients who might have had rheumatic fever and developed rheumatic aortic valve stenosis, and the most common of which in the state of California is calcific degenerative aortic valve stenosis. It's calcification that takes place over time. And I'm going to show you how that happens, because I think if we could find a way to stop it, even though I would, not be able to do TAVR in as many patients, which I enjoy, but if we could find a way to stop the progression of aortic valve disease, it would help patients even more than doing procedures. So we see that more common is age-related calcific degenerative in Northern California, rheumatic fever, not so much. Outside of the borders of California, we see a lot more patients who've had a history of rheumatic fever. Here's the interesting thing about the valve itself. If we look at the aortic valve, it's made of multiple different layers, believe it or not, a top, middle, and bottom layer that have these valvular endothelial cells, which normally provide protection. The leaflet itself is not that thick, but it's a thin layer of tissue, but it's normally intact and it opens and closes quite easily, and there's no issue or problem with it. So how do we actually get aortic valve stenosis? It's actually quite interesting. I'll only show you a few slides, though there's at least 20 or 30 minutes I could tell you about it, but we get a breakdown of these valvular endothelial cells, which allows red blood cells to come in. These valvular interstitial cells right below it tend to break down these red blood cells, and we get iron deposition within the leaflet itself. And that iron deposition starts this process where some of these valvular interstitial cells actually get changed. They get what we call this mesenchymal transformation. They go from doing their job to being told to do another job. And what they become is some of them become cells that are actually like our bone cells that start to lay down calcium and almost try and create bone within the middle of the valve. And we get this calcium deposition underneath the leaflets. And this calcium deposition becomes so great and so much that it pushes through the top part of the valve, and we get a very calcified and stiff leaflet instead of a very pliable leaflet. And the question is how to prevent this from happening. And we've tried different ways and can't figure it out so far. And here's some pictures of the valves on the left, and on the bottom, you can see kind of the microscopic views, how we get this calcium deposition in the middle of the valve itself, and it becomes verrucous-like and pokes through the top part of the valve with these age-related degenerative valve patients. Well, the disease process is not going anywhere, right? We're having patients live longer. And from 1990 to 2020, the population almost doubled in patients over the age of 65. And we're just heading upward from there, right? So we have tens of millions of people over the age of 65, and somewhere of 7 to 10% of those patients have aortic valve stenosis. So we're talking about millions and millions of people that are needed to be treated. Well, the classic way to follow patients with aortic stenosis is by ultrasound or echosonography. We follow the blood as it leaves the ventricle, as Dr. Balmer showed you, goes through that aortic valve. The smaller the hole that the valve has, the faster the blood travels. And we follow the speed of that blood as it goes through the valve. And we look at the velocity. We look at the measured gradient, how much higher the blood pressure is in the left ventricle compared to the aorta. And we look at the valve area. And as Dr. Balmer stated, when that valve area is less than 1, these patients absolutely get into trouble. But we should be seeing these as cardiologists when that valve area is somewhere around 1.5, so we can start to follow them and make sure that we don't get the point of palliative care. And Dr. Balmer is right. I see so many patients right now who come in intractable heart failure, the squeeze of their heart is down, and they have aortic stenosis. We should have treated this many years before we actually do. So we are underdiagnosing, under-referring, and under-treating patients. And there are other ways that we can look at aortic stenosis. Not everyone has this high velocity state, but I would ask you just to remember that if you see a valve area less than 1.5, that patient already has early aortic stenosis. If that valve area is less than 1, they already have severe aortic stenosis. And let us help you take care of these patients from a cardiology side of things, and we can work out the details about workup and how to get them a proper therapy. Well, if we back up to the early research, let's go back to the 50s and 60s when we first started to work with and identify patients with aortic valve disease, and doctors Brunwald and Ross working on following patients with aortic stenosis. And at that time, most of the patients were rheumatic in nature because they were not living long enough to get calcific degenerative. And they wanted to follow the natural processes or the natural pathways of patients, the natural history of patients with aortic valve stenosis, and see what actually happened to them. What is their lifespan? What happens to them? And how can we potentially treat them? Early on, from a surgical side of things, we didn't have surgical aortic valve replacement, but they did commissurotomy. they found ways to actually put little catheters within the ventricle of the heart, and then put these little biotomes, these little commiseratomes that look like these big metal objects that were enlarged and then deflated, that tried to break up all the calcification and the commiseral fusion that took place in most of the patients that had rheumatic heart disease. And this is the early way we did it. And they found out that sticking large catheters through the ventricles probably not the best way to treat this, but that's all they had at that time. And the mortality rate early on in some of these patients was upwards of 17 to 20%. So it is very difficult to think about referring a patient for a procedure where 1 in 5 of them might not survive. They decided, well, maybe going from the top from the aorta might be better. They found ways to sew on little attachments to the aorta, put their finger through the aortic valve, and then also using these commiseratomes from up top, they said, above the valve coming down. And the mortality rate was a lot less. But again, the same procedure, just from above the valve. It helped to open the valve, but patients lived longer, but it didn't cure them of their disease. So they were amazed even after doing some of this, that some of these valves were so tight that they could barely get their 3 to 4 millimeter devices across. And they knew even back then, this is in the late 40s, early 50s, that attempts must be made to treat patients at an earlier stage, and that many patients needed to be either have this commiserotomy done from up above, but they needed to find a way to do something more. And this is where everyone started to get involved. And that's Dr. Bailey, who did some of the early surgical work for aortic valve therapies, made the cover of Time in 1957. So we've made it to the 50s or so, and this is a paper for Dr. Brunwald and Ross and colleagues that Dr. Balmer showed you, that they followed these patients, and they found out that in their early 60s, they usually had the onset of symptoms. And those symptoms were shortness of breath, chest pain, dyspnea on exertion, syncope. But once you had the onset of symptoms, doing nothing led to certain demise of these patients. They were going to die no matter what. No medical therapy, as you heard about, was going to fix them. And that's a published paper in 1968, right? We're talking almost 20 years later before we come up with some sort of alternative therapies, right? Some patients could not go to the operating room. We eventually got into the point of we did do surgical aortic valve replacement, but Dr. Cribier and colleagues came up with a way to maybe trying to balloon this valve, not to use these commiseratomes in a surgical way, but to do balloon aortic valvuloplasty, expand a balloon inside the valve and see if we could make the patients better. And they could do this from a catheter-based approach and not a surgical-based approach. And remember, back in the 70s and 80s, even being over the age of 70 was considered an increased risk factor for surgery, and many patients were turned down for surgery. So they found ways where they could go in, put a balloon across the aortic valve, stretch open the valve, and then patients could do better. They did a few patients and then started to publish their results, and then did some larger trials about balloon aortic valvuloplasty. And here's some of the initial pictures of them inflating a balloon inside the valve itself. The pressure tracings on the bottom left shows the higher pressure in the left ventricle, the lower pressure in the aorta, and after successful inflations of 8, 10, and 12 millimeter balloons, that gradient is less. The pressure in the left ventricle is less. The pressure in the aorta could be as good or higher, and we've alleviated some of that obstruction, decreased some of the stress on the myocardium, and patients could feel better. But it wasn't permanent, right? They started to put on these live courses outside the United States to teach physicians how to do balloon aortic valvuloplasty, because it was a non-surgical temporizing approach to patients that was more successful than doing nothing, which was akin to medical therapy. Medical therapy, as you heard, does not work. So they found that these routine high pressure with a balloon would expand the leaflets. But what they also found out through some of these other trials in patients who had already passed away, on some cadaver trials in patients with AS, is that they actually could put a stent in there. If they could put a stent in there to hold open the leaflets, they might find a way to get a new heart valve in there without having to have surgery. So the premise at this point was, hey, we can't hold open these leaflets. And started to find ways that we could put stented structures in there to hold back the leaflets. Well, what we figured out is that the mortality difference, if you take someone to the operating room and replace their valve, they did just as well as patients their age who didn't have AS. But if we tried to medically treat symptomatic patients or medically treat even asymptomatic patients, they died quickly. Specifically, the medically treated symptomatic patients, the bottom left-hand curve, these patients died very quickly, with the 5-year mortality greater than even the worst metastatic cancers. So leaving someone untreated leads to almost certain demise and death. And I will tell you that this asymptomatic population is going to be treated very quickly with valve replacement as well. The majority of patients not having a surgical option because they had multiple comorbidities, including lung disease, kidney disease, age, which again, early on, over the age of 70, right? So we needed to come up with alternative strategies. Well, I will tell you that the first attempts of these in 1989 by Dr. Anderson, cardiology out of Denmark, he actually went to a talk by Julio Palmaz. And Dr. Palmaz and Schatz came up with the first stents, the Palmaz-Schatz stents that were put into vessels to hold them open. He went to a meeting in Arizona with Dr. Palmaz, heard about him putting stents in vessels, and said, I think we can do that to the aortic valve. He went home, went down to the local butcher, got pig hearts. He took the valves out of the pig heart himself, and he created this metallic structure that he could put into the vessels, initially into the aorta, and then inside the valve of pigs as early research. And here's him showing you that he hand bent, and hand crimped the metallic frame himself, and then hand sutured the aortic valve of the pig onto this frame. He then tried to collapse it and squish it down into this very large tube. And then he mounted it on one of Dr. Cribier's balloons that he had used for balloon aortic valvuloplasty. And he said, listen, if I crimp this down, but I put a balloon underneath it, when I inflate the balloon will stretch out my stent, inflate the valve, and we can put this in different places. And this might actually work. He was the first one to come up with it, the first one to do it just a few months after he came up with the idea. And he couldn't get anyone to pay attention. He tries to present his work at the Danish Society of Cardiology. He submits his abstract. No one will publish it. He sends the paper to JACC and Circulation. They said it's too low priority. Ultimately, the European Heart Journal in 1992 publishes his results. And he had done over 40 animals at that time. At the same time, Dr. Cribier was working with placing these Palmaz stents inside of stenotic valves in patients who had passed away. And he came up with the idea that, you know what, the ideal height for this stent might be about 14 to 16 millimeters so that we don't interfere with the patient's normal electrical system, normal mitral valve, and normal conducting system. And by proof of concept, he could put these little stents inside the calcified valve, put a little hook on there, and he could lift the entire heart up and not have the stent come out. So he thought, well, if we can do this, if we can find a way to put a valve inside of this stent and find a way to get this stented valve structure inside the patient's native aortic valve, we have a chance. This might actually work. And again, despite his prowess within the field, he can't get anyone to pay attention. Another 4 years go by, no one wants to develop the concept. They call it actually the most stupid they've ever heard. So eventually he and Dr. Leon start a company called Percutaneous Valve Therapies in 1999 in New Jersey. And they get some engineers out of Israel to help design and develop their concept of a valve. And they said the valve's got to be compressed down to 7 to 9 millimeters. And they come up with an initial valve that can be expanded to 23 millimeters. And eventually they do a lot more research. They do a lot more sheep implantations and prove that, hey, this valve that we came up with, we can do it. We can go in through the femoral artery, go across the aortic valve, inflate our valve stent structure, and it stays. And the patient goes from a very severe aortic valve stenosis to no aortic valve stenosis. And again, these are the early concepts and prototypes and designs. And eventually you have to try this at some point in a human being. In April 16th of 2002 in France, they have a very sick but young 57-year-old gentleman who's in intractable shock. The squeeze of his heart is down to almost nothing. He's on multiple agents to raise his blood pressure. He undergoes balloon aortic valvuloplasty, and it doesn't help a bit. The caveat to this is that patient already had horrible peripheral vascular disease. He had aortal bifemoral bypass, and the bypass grafts were not working very well. They could not get from the leg to the heart. So Dr. Cribier calls Dr. Leon across the water and says, listen, I've got this very young guy. We're not going to be able to go from the legs. We're going to have to go from the inferior vena cava, across the interatrial septum into the left atrium, across the mitral valve. and then go up and place it that way. And Dr. Leon says, well, we got to try it on someone. This young gentleman at 57 is going to die if you've done nothing. He's been turned down for surgery. He's too high risk. He's on multiple pressors. And he said, you know what? I think we should try it. And Dr. Carribius, to his credit, said, listen, there's a high likelihood of failure, but it just might work. And if it does work, it will save his life. So in April of 2002, they decided to try this. The wire you see on the bottom left here goes across the interatrial septum, through the mitral valve, up through the aortic valve. And that's how they placed their initial valve, in a way that they did not even design to place it. They meant it to go retrograde through a femoral artery approach and come back and around from above. And they already had to ad-lib the first time they placed this in a human being, and it actually works. Here's Elena Cheninoff and Drs. Tron, the two that did most of the animal work, and should not be forgotten as we develop this TAVR story, because they were integral in developing the valve itself. And there's that valve, transseptal approach, April 16, 2002. And of course, right after this in France, you're allowed to celebrate. You can have champagne. The patient comes off pressors and he leaves the hospital, right? And eventually he will die of non-cardiovascular related condition. So just like the initial balloon angioplasties and the first stents placed in coronaries, luckily this procedure worked the first time through. Well, they do a few more patients, they do some feasibility trials, and eventually Edwards Life Sciences buys the company in 2004 for probably the best and most well-spent $125 million any company's ever spent. And then they developed different size valves. And another valve is going to be developed at the same time, which I'll tell you about. And then I'll tell you where we are today for these particular patients. So the initial valve gets developed. It can be crimped down very tight on a balloon, but it doesn't injure the stented structure. And the second valve is a self-expanding valve founded by a cardiothoracic surgeon, also in Paris in 2001. Parallel to the placing of the Edwards valve, the initial balloon expandable valve, they were developing this valve as a self-expanding valve. And eventually in 2004, they placed the valve in their first human being. And I will show you how this is done as well. This is a very tall self-expanding valve placed through a transfemoral artery approach. We then go across the aortic valve and let this valve sit within the aorta itself. Well, there has to be clinical trials, right? There has to be clinical trials in the United States that prove that this can be done safely in human beings. And the initial patients that were done were the highest risk of patients who were turned down by two cardiothoracic surgeons who said, we cannot do anything for this patient. If you want to put a valve in this patient, go ahead. And these are the inoperable patients. And shortly thereafter, a group of high-risk surgical patients who had a high likelihood of complications, death, stroke, myocardial infarction, heart failure, prolonged hospitalization, and they were randomized to a transcatheter valve versus a surgical valve. And these are the first two early publications related to valve replacement therapies that was presented to the FDA and got approval for these valves to be done in 2011 and 2012. And luckily, we had been doing research on these valves before that time, and we were able to start placing these valves right away after FDA approval. But the initial valves were not perfect, right? The IVs that we had to put them through, we call those sheaths. The sheaths were too large, and we couldn't get them through half of our patients. Half of our patients, we had to go through an alternative means of placing the valve in there. And a lot of times we made an incision through the apex of the heart and went through the chest wall to place the valve. Now, we already knew from the surgical literature in the 1940s and 50s that doing commissurotomy through a left ventricular apical approach didn't go that well. And we found the same thing. That would help certain people, but man, was it really hard to recover from. We had to improve about pacemakers. The electrical system sits real close to the valve that we put in. Pacemaker rates were higher. The leak between our transcatheter valve and the native valve was higher. And the stroke rate was nearly 8%. These were too high, but it was the first iteration. So what happens? We get better. The sheath size gets smaller and smaller and smaller. The type of valves that we put in get better and better and better. We wrap them with a little covering now, a skirt around them to prevent leak. They're designed different. The cell design are different. The sheath sizes are different. And the types of valves we put in are different. So now we can tailor it to each individual patient. And eventually we get to low risk patients. We did moderate risk patients, then low risk patients. The most recent of trials here in 2019 or so, looking at balloon expandable, 1,000 patients low risk, randomized to surgery or a transcatheter valve and following up. And again, bicuspid patients not in this trial. And as you can see, if we look at the death, stroke, or rehospitalization rate at 1 year, it was lower for transcatheter valves compared to surgical valves in a low-risk group of patients. Death from any cause, lower with the Edwards valve than surgery. Stroke rate lower, right? We had a higher stroke rate in the initial trials. One of the limitations that surgeons would say, listen, you don't want to give 8% of your patients a stroke. Now, if you look at it in a low-risk group of patients, the risk of stroke in TAVR is 1.2%, 3% with surgery. And the rehospitalization rates are less. So we proved that not only could we do this, we could do it safer than a surgical procedure, and the best hospitals in the country and in the world being involved in these trials. Well, we did the same thing with these self-expanding valves, the Medtronic valves, looking at 1,400 patients with symptomatic aortic valve stenosis, low risk, no bicuspid valves, and they followed them. And again, the end point for transcatheter valves, even to 2 years out, was less with transcatheter valves compared to surgery in a low-risk group of patients whose average age could be 60, 62, 63. So here's what the valves look like. So now what we're talking about, and I'm going to show you how we place these valves, the pacemaker rates are down to about 6%. 97% of the patients now are done by a transfemoral approach, by going from the leg. The stroke rate, as you see, is down to around 1 to 1.5%. Majority of these valves are placed in cath labs, does not have to be in an operating room type setting. And even in some places, nurses are doing the anesthesia. It's not general anesthesia. It's conscious sedation, femoral approach, 50 to 60-minute procedure. Patient usually goes home the next day, though some centers are sending them home the same day. So we went from a 5 to 7 day hospital stay with a higher stroke rate and complications to a one-night stay. I got fresh cases. I just wanted to put in some new cases. These are cases we just did yesterday. In some patients, we put these little nets up in the structures of the head and neck to try and catch debris. And I just wanted you to see what that looks like. We have a little net up in the right innominate, and we can put another net up in the left common carotid vessel. And this is a patient looking at you with their head at the top of the screen and their feet at the bottom. What we do is we come in from the leg and we put these little pigtail catheters, and we're taking a picture of the aorta itself. One of the wires you see in the bottom left is a temporary pacing wire, because as we place these valves, we pace the ventricle at a very high rate to make the blood pressure go down so that the left ventricle itself does not kick our valve out and send it flying into the aorta somewhere. So what we're doing is just trying to determine where the valve is, getting what we call the annular plane line laid out so that we can see where we're going to place the valve. In some patients, this patient had a very heavily calcified valve. We did that balloon aortic valvuloplasty, which we've shown you. Now we have bigger balloons, 20, 22, 24, 25 millimeters that we can use to stretch the valve. And if this balloon procedure were more effective, that might be all we need to do. But these valves are so calcified, they just come right back down, and we haven't cured anything. So what we do in this next particular patient is we just bring the valve in. The valve is mounted on a balloon. We put it in place. We slowly expand the balloon. The stent itself pushes the valve leaflets out of the way, and we're left with a new valve inside the patient. We've pushed the old valve out of the way. The new valve stays behind. They go from critical aortic valve stenosis to no aortic valve stenosis. We take our catheters out and we move on. These patients are all screened with CT scans ahead of time to make sure that the size of the vessels in their leg are appropriate, and that we're not going to block off the blood flow to the heart when we do this. But the vast majority of patients qualify for this. This is an 82-year-old patient. And the patient right after that, we brought in, I'll show you a different valve, a self-expanding valve, which we also did balloon aortic valvuloplasty. Again, a patient with multiple comorbid conditions who TAVR was deemed to be a better option. But I will tell you now that any patient over the age of 65 should clearly be considered for TAVR versus a surgical replacement. Here's that self-expanding valve. We've got a transesophageal echo probe in this particular patient because they were sick and we needed to figure out a few more things about their heart. And this valve is slowly released, slowly pulled back. There's no balloon procedure. This valve is kind of put inside the tube and we slowly pull back the tube. We slowly expand this valve. We move the patient's native aortic valve out of the way. And inside these valves, as I've shown you, are either bovine or porcine pericardial tissue. And we release these valves in a slow and steady way. And the patients go about their business. And again, both these patients went home this morning. They both had their valves done yesterday. We kept them overnight. Dr. John Webb says, hey, if you put a valve in someone, maybe you should at least buy them dinner and breakfast the next day. So, but I will tell you that patients will be going home the same day. So these patients did quite well, and the vast majority of our patients do well. So I'll end with a final few slides to say this is done routinely now in 700 to 800 centers within the United States and even more throughout the world. It's done in centers that have just cath labs, not hybrid ORs. It's done in centers that have surgical backup. But I will tell you, in other centers without surgical backup, it will eventually be done as well. It can be done very safely. And I will tell you, in trying to help you believe that we can do this safely, is that even in patients with asymptomatic aortic valve stenosis, we know that they don't do as well. Truly, patients are not asymptomatic for the most part, and we don't put them through the proper testing to determine whether or not they have symptoms or not. We just ask them, you have any symptoms? They say no, we go, good, move on. Right? That doesn't work. These patients are dying, and they should not be dying of a disease process that can be treated and cured. It's a mechanical problem. It requires a mechanical fix. Here's what we will begin to follow. We will begin to follow these stages of patients with aortic valve disease. On the far left, the patients that are healthy, the far right, the patients that are not as healthy. We would prefer to take a patient that has no cardiac damage, right? The squeeze of their heart is good. Their mitral valve is still okay. They haven't developed pulmonary hypertension, and their right ventricle still works. The farther we go from left to right, the more damage we're allowing to be done to the patient's heart before we replace the valve. We were part of a trial here called the early TAVR trial, where we'd randomize patients that were asymptomatic. They had to be able to go on a treadmill, pass the treadmill without symptoms, have a good squeezing heart, and we randomized them half to transcatheter valve replacement, half to watchful waiting, and only replacing valve when they had symptoms. That trial is now closed, and the results of which are being gathered and hopefully will be published soon. I am a firm believer that we will be replacing aortic valves in the absence of symptoms in the near future. We are waiting for something to break before we do it. And this shows you, if we wait till stage 4, 3, 2, or 0 to do these particular patients, how do they do at follow-up? Well, the mortality rate is quite high. You can imagine even at 4 years, patients that had stage 4 even got their valve replaced, we still have 40% of them had passed away, as opposed to just 8 or 9%. And this is, again, a group of patients that had valve replacement. So the earlier we can get to patients, we can reduce their overall death and complication rate, and we can reduce their cardiovascular death. But we have to start replacing valves sooner, right? Cardiovascular death at 8 years was 4% in these patients when we got them at an early stage, stage 0. When we wait till stage 3 or 4, we're waiting too long. And waiting too long to do it now means they're not going to get the benefit they should be getting in the long run. I will show you one slide about aortic valve insufficiency. This is a research-based valve, the trial of which now has closed, called the JenaValve. It is not FDA approved, but for patients with severe aortic valve insufficiency or a leak without stenosis, there are valves that are being placed and valves that are being designed specifically for those patients. And again, this is done by a transfemoral approach and will likely be coming to a theater near you shortly. I'll end with just telling you that whether you have a TAVR-based program at your facility or not, the recommendations are that all patients with valve disease should be considered for valve intervention at a facility that can offer transcatheter valves and surgical valves, a comprehensive valve center. I think TAVR should be the team approach to valve replacement. It involves cardiology, CT surgery, our nurses, cath lab perfusionists, and everyone to get involved. Echo techs, echo people at your hospitals who pick up aortic valve stenosis and then do nothing about it, right? The echo techs can be the first line to highlight this to the reading cardiologist, to the reading primary care doctor to say, hey, your patient has a valve problem. We should look at getting this fixed. And I always remember the first 2 patients we did, 91 and 92 years old, that knew we had never done this procedure before. And they allowed us with courage to replace their valves over 10, 11 years ago with great success. and they were back out doing the things they wanted to do a few days later. So I always give them credit because they trusted us when we didn't have the experience that we have today. And I'll end right there, Dr. Bomber.
Thank you very much, Jeff, for that that wrap up of the last 10 years of progress, which has been truly remarkable. We're going to, at this time, we're going to run into our next presentation, and I wanted to share content again. So if we could take your slides off, and I will share content with mine to introduce the next speaker. So I am now sharing content, start broadcast. And hopefully you see my screen. So can you see my screen on your slide?
We can see that it says that you've started sharing screen, but it's just a black screen so far, Bill.
Okay, I'll hit it again. Hang on. So share screen, you are sharing screen, yes. And you should see the slide. Correct?
No, we're just still seeing a black screen, but
Okay,
we do have
Albert, can you make sure the screen share is available?
Yes, it is available.
Okay, so I am on. I will stop share again. I'll start and then I'll share content again. Screen.
And Bill, I think it's possible that Albert could share slides and then he could just forward them for you.
Okay,
There,
I'm gonna
we got
look
him.
right.
We've got your screen, I think. It's a figure 3 example of a moderate aortic stenosis. Is that what you want?
All right, okay.
Perfect, great.
Well, thank you very much, Jeff. That was impressive. We're moving on to another type of hypertrophy. On the left side of the screen, you see a high velocity jet on Doppler, which is going to correlate to a significant valve obstruction for aortic stenosis. And you see on our echo Doppler, you see a high velocity, which would be expected if you have a narrow valve associated with it, which would give you a pressure gradient across the valve, typical of valvar aortic stenosis. On the right side of that same screen, you see another one with, again, a velocity that's even higher. Instead of 3 to 4 meters per second, it's 5 meters per second. And this was typical of the first patient who was recognized with hypertrophic obstructive cardiomyopathy. At the NIH, they received a patient. They found a high pressure gradient across the valve. They thought it was aortic stenosis on the left. And Dr. Brunwald and Mason sent the patient to the operating room, and the surgeon opened up the aorta and said, the valve is normal. There's no aortic stenosis, and sent it back to them in the cath lab. And they had to, in fact, sit down and figure out, if it's not the valve, where is this high velocity obstruction, which can mimic on echo and on cardiac catheterization, aortic stenosis. And what they were able to determine was the obstruction was not at the valve level, but as I showed earlier, just below the valve level, this being hypertrophic obstructive cardiomyopathy. The obstruction was in the left ventricle that they had for that. And I guess this is, Albert, is this your slide, or I'm not advancing? There we go.
Yes, I'm advancing.
Okay, so hypertrophic cardiomyopathy. is the most common inheritable cardiac disease. So we think, oh, this is pretty rare, but it occurs in 1 in 500 of the general population for that. And about 2/3 of the patients with hypertrophic have a significant gradient across the outflow tract. So this is a relatively common inherited disease that we see, for which we have put patients on initially beta blockers, verapamil and disopyramide initially, but there are still a significant number of patients, perhaps 10%, that remains symptomatic on optimal therapy. And in the past, we had septal reduction with either surgery, myectomy, or alcohol to try to reduce that obstruction. Next slide. And what we see is the obstruction is shown there because the muscle just under the aortic valve leaflet gets so thick that it obstructs the flow out the normal aortic valve at that point. And to the right, we see the surgical procedure is to insert a knife or scalpel in the aorta and try to cut off or whack away parts of the ventricular septum there to relieve that obstruction. This is a technically very difficult procedure and has significant adverse events if, in fact, the bite is not done absolutely perfectly, and frequently requires a pacemaker as well. The other approach is not a knife resection of the muscle, but is to inject alcohol, shown on the left of the slide, into the ventricular septum. The alcohol leads to a raging vasculitis of the septal vessel, leading to thrombosis of that vessel and immediate heart attack or elevated myocardial infarction in the area of the septum. That area of the septum then dies, and because it's dead, it can no longer contract and lead to obstruction in that case. Next slide. And so what we see is the alcohol ablation does give a relief. And if we look on the slide on the right, we see that there's pretty good reduction in 50 to 70% of the patients, but not all patients get a benefit from it. But it is at this point in the past was our best therapy to offer, in addition to a surgical septal removal of the ventricular septum. Next slide. But today we have a new option, and the new option is a strikingly new class of medicines, Camdens, which are myosin inhibitors, and they really reflect the process itself. It actually inhibits myosin in its binding to actin. And so hypertrophic obstructive cardiomyopathy is associated with hyperbinding of the actin and myosin in the heart, leading to significant overcontraction and muscle building and muscle thickening at that point in time. The myosin inhibitor is a way to relax the muscle so it does not overly contract at that point in time. And we're delighted today to have Dr. Milind Desai from the Cleveland Clinic, who is the Director of Clinical Ops and Director of the Hypertrophic Cardiomyopathy Center at the Cleveland Clinic, to present what I believe is some groundbreaking therapy, where he in fact looked at the myosin inhibitor medical therapy, newly FDA approved, and compared it in individuals who would normally have to have a surgical or interventional therapy for it. So I'm very impressed that Dr. Desai is with us today. The two things on his CV that are there, I'm not sure which one is more difficult, being the director of the Hypertrophic Cardiomyopathy Center or director of clinical operations for one of the largest healthcare systems in the United States. But we're delighted that he was able to give up his evening, step aside for a minute, to provide us with information about his landmark trial that he performed. Dr. Desai.
Thank you very much for the kind introduction and the invitation. I'm going to share my slides and please tell me if you see them. Yes? Can you see the slides?
Yes,
Yes.
yes.
Perfect. All right, beautiful. So thanks a lot. And I'm happy to be presenting this, albeit virtually. So what I'm going to talk about, take you through a conversation about how I look at hypertrophic cardiomyopathy in my little brain. Here are my disclosures. So let's start with some basic simple mathematics. Assuming that the prevalence of HCM is about 1 in 500, you can expect around 700,000 HCM patients in USA. As of right now, we know of only about 100,000 patients that have been diagnosed. 2/3 of them, as Dr. Baumer had suggested, have obstructive phenotype, and the rest have non-obstructive phenotype. But I'm more interested in what's happening to the other 85% or other 600,000 Americans who may have HCM. Either they are underdiagnosed, misdiagnosed, or just simply not diagnosed. If you extrapolate the math in the world, now we are talking more 16 million patients, of which if 85% are undiagnosed, now we have some serious problems, serious challenges ahead of us. Some people say that the prevalence may be more closer to 1 in 200. So that's even a bigger issue. So before we talk about newer therapies, I'm going to say there's lots of opportunities to improve the diagnosis, and there's a lot of patients to treat. Now, who takes care of HCM patients? Why is this important? About 80% patients are managed in a community cardiology office without a dedicated HCM program, and only 20 to 30% are managed in highly experienced HCM programs. So certainly, what we need to do is expand the pie of disease recognition by way of improving education in forums like these. What is step one in my mind? You have to image and establish the phenotype. You have to establish the diagnosis and clearly also have an understanding if you are dealing with a phenocopy or not. You have to be able to ascertain the symptoms. Are the symptoms coming from outflow tract obstruction, which could be dynamic, meaning at rest or with provocation? Is the outflow tract obstruction due to basal septal hypertrophy? Or is there some other bad actor like mitral valve leaflets or papillary muscles? Or the symptoms, are they without outflow tract obstruction in the context of diastolic dysfunction or apical hypertrophic cardiomyopathy? What is the risk of sudden cardiac death? What are some of the familial and genetic implications of this disease? So not all HCM is thick walls, and not all thick walls is HCM. I have two scenarios here, okay? Both these patients have clinical hypertrophic cardiomyopathy with dynamic LVOT gradient. The person on the left has your standard very thick walls in the basal septum, but what about the person on the right? This person has no hypertrophy. The ironic thing is the first person is gene negative for HCM. The person on the right is gene positive. So obviously you cannot do a myectomy in the second person, and you can treat the first person with a myectomy. Bottom line is you need different strokes for different folks. There is indeed value of a tailored approach. Most people would like to look like the guy in the bottom, not the young kid with a big man suit. So you have to have a tailored approach to diagnosis and management of this disease. Multimodality imaging is absolutely crucial in 2022 for diagnosis and phenotyping. All these 4 patients have hypertrophic cardiomyopathy. Top left is your standard HCM. Top right is your apical variant. Bottom right is somebody with no hypertrophy, but due to papillary muscle problem, as you can see, the papillary muscle is bifid and hypermobile. And the bottom left is somebody who has concentric LVH. While echo remains the mainstay, with the emergence of advanced imaging, especially CMR, we've gotten to be very much more into the details of diagnosis as well as tissue characterization. CMR is highly accurate for tissue characterization as well as volumes, ejection fraction, wall thickness assessment. Second point you have to think about is you have to elicit LVOT obstruction. If you don't look, you won't find. If you won't find, you can't treat. It's as simple as that. So if you look for outflow tract obstruction, using provocation, you will see it in 70% patients. If you don't, at rest, you will only see it in 25%. So this patient is a patient of mine who was told they have no HCM because they have no hypertrophy. But when we provoked them with amyl nitrite, this person had the same reproduction of symptoms and a severe outflow tract gradient. We know from prior studies that having obstructive physiology is associated with worse long-term outcomes compared to no obstructive physiology. So designating somebody as non-obstructive HCM without the full extent of provocation is not appropriate. Stress echo provides a useful adjunct to standard testing. Not only it can risk stratify, but it can also elicit outflow tract obstruction as well as look for arrhythmias. Again, patients' perception of their symptoms can be misleading. This is a study on almost 430 patients in which only 18%, 1 in 5, achieved their predicted METs. The rest of them did not. And the ones who did had good long-term outcomes versus the ones who did not. This is survival. The other aspect is in 2022, you have to be able to recognize the typical and atypical variants. The most common variant is the standard hypertrophic variant, but you may have mitral valve and papillary muscle abnormalities, all kinds of things that can cause LVOT obstruction and symptoms similar to what you find in garden variety HCM. So designating somebody as not being HCM simply because they do not have hypertrophy is also not appropriate in 2022. These are 3 examples. These are all 3 my patients. So the first one on the top has a mitral valve pathology. The middle one has papillary muscle pathology. And the third one, bottom one, has abnormal caudal attachment. Each one of them is causing late peaking dynamic outflow tract obstruction with symptoms. I can assure you surgical myectomy or alcohol septal ablation is not going to fix this problem. You need to get creative with this. Another important thing is differential diagnosis, because a lot of phenocopies masquerade as hypertrophic cardiomyopathy. Again, with the advent of advanced imaging like cardiac MRI and strain imaging on echocardiography, you can do a good job of differential diagnosis. Careful to be looking for athlete's heart, amyloidosis, Fabry's disease, as well as some of the other phenocopies in the context of HCM. So multimodality imaging is absolutely vital. Having said that, I like to show this slide. This is a very humbling slide. These are almost 2,500 myectomies done at the Cleveland Clinic on HCM patients sent by experts for heart surgery to relieve obstruction. Having said that, 1 in 5 at the Cleveland Clinic, we found had an alternative diagnosis. So even our best efforts at advanced imaging, you can still falter. So you have to be very diligent in your approach to diagnosis. Now to the meat of the conversation. What are some of the key principles, things we know or we think we know, but we have to be careful about? Avoiding volume depletion, because small volume depletion results in small LV cavity that can exaggerate dynamic LVOT obstruction. So eat small meals. The hot, humid environments need to be avoided. Alcohol is a bad actor as a depressant, can dehydrate you, and also a huge risk for AFib. It is important as first line, at least based on guidelines, current guidelines, it is recommended first line therapies, beta blockers, calcium channel blocker, like verapamil and diltiazem and disopyramide. Need to avoid afterload reducers and nifedipine, nitroglycerin, digoxin. Diuretics may be a necessary evil in advanced cases of volume overload, but otherwise in earlier cases, it can be a bad actor. Important to recognize obstructive sleep apnea as a concomitant existent, and you have to be screening and treating that. Now, in a well-managed patients, they can pretty much do a lot of aerobic activities. Athletes, the world is evolving, more data will emerge in the next few years, and the restrictions on physical activities are getting lesser and lesser. Pregnancy, I tell them, go at it, we will take care of you after the fact. And it is important to prevent and treat comorbidities because a patient with comorbidities, they tend to do worse. Risk factors, they still create problems. Now, few important things here. There are no prospective studies, single or multi-center studies, comparing various FDA-approved medical therapies, invasive therapies versus FDA-approved medical therapy, myectomy versus alcohol septal ablation. There was a recent small study comparing beta blocker versus placebo, which did not show an improvement in physical exercise capacity, but it helped some symptoms and reduced gradients. So before the approval of cardiac myosin inhibitors, the best guideline recommendation may have been class 1, but it was based on level of evidence C, which is basically a consensus opinion. I'm going to say a word about disopyramide. A lot has been written. This is truly a third-line agent, has been used in the context of HCM since 1982. It originally developed to treat arrhythmias, but also found to have negative inotropic activities, and so used in the context of HCM. But it has a fair bit of side effects. Torsades, dry mouth, anticholinergic effects like urinary hesitancy, constipation, cannot be used with glaucoma, etc. The important thing is, despite all that conversation, there's no prospective data in the context of disopyramide. Everything is retrospective observational data, and only 66% patients tolerated this drug. Non-obstructive HCM, basically, if you have preserved EF, you treat with beta blockers and non-dihydropyridine calcium channel blockers. If you have advanced disease, you treat them like HFrEF, and consider standard HFrEF therapy. In some centers, we do apical myectomy in carefully selected patients to help improve the stroke volume, etc. Basically, not much out there in terms of therapies. And there is emerging data in the context of mavacamten and cardiac myosin inhibitors. AFib is truly a bad actor in HCM. All studies, all databases I've looked at, AFib is associated with worse long-term outcomes. The unfortunate reality is success rate of ablation for AFib is less than 50%. And at least in our practice, we are evolving towards, if you have outflow tract obstruction and you have AFib, then we consider that as an earlier trigger for surgical myectomy. AFib, of course, irregardless of what your CHA2DS2-VASc score is, you should be anticoagulating these patients. Okay, make no mistake about that. Irrespective of CHA2DS2-VASc score, you need to be anticoagulating these patients. And you should be aggressive with rhythm control as well as cardioversion and AFib ablation. At the time of surgery, we strongly recommend concomitant MACE procedure. Now, moving on to the main dish of the conversation, cardiac myosin inhibitors. Mavacamten is the first line. It is an allosteric inhibitor of myosin, which stabilizes the myosin in a resting state. Essentially, what it does is it reduces the actin-myosin cross-bridging to reduce hypercontractility. Bottom line is it improves compliance, diastole, and improves energetics, basically. It does not affect calcium flux. As a result, it has low arrhythmogenic potential. This is a basic science slide where it stabilizes the energy-sparing state of the myosin, which is disrupted by HCM mutation. So the top panel shows in a healthy heart, most myosin is in an energy-sparing closed state like this on the right. And in an HCM heart, it is in an open state. So what mavacamten does is it restores the balance between closed and open states in skinned cardiac fibers, so improving better utilization of energy and contractility. What has the animal data shown? Treatment with mavacamten also reduces profibrotic gene expression. So if you treat mice with mavacamten for about 16 weeks, either early or late, it reduces expression of profibrotic genes. Additionally, what it has been shown in genetic mouse models, it has shown that it prevents the development of hypertrophy, it prevents the development of fibrosis, it can reverse hypertrophy once you have developed it, and it also further blunts the pro-inflammatory and pro-fibrotic signaling. So basically, it has the potential of altering the downstream structure of the heart towards the better. What does the human data show? Phase 3, there are 2 phase 3 randomized controlled trials comparing mavacamten to placebo. Now remember, in the history of HCM, there have not been any large randomized control trials till now. Explorer and Valor are the 2 pivotal trials, ranging the full spectrum of the disease. Explorer, patients had NYHA class 2 and 3 symptoms and only monotherapy. They did not allow standard combination therapy for these patients. Valor included patients that were NYHA class 3 or higher, used combination therapy. Disopyramide was also allowed, and each patient in Valor was advanced enough, meeting criteria for septal reduction therapy, was referred for, and was actively considering scheduling for SRT. So what did the data in Explorer show? The bottom line is Explorer patients, majority of them, 72% or thereabouts, they were in NYHA2, which means earlier in the disease spectrum. What the data showed is on the panel on the right, it significantly reduced outflow tract gradient, not only at rest, but with exercise as well as with Valsalva, without any impact on the ejection fraction. The primary endpoint was grossly positive in mavacamten versus placebo. It improved your peak VO2 by more than 1.5 mils with more than 1 NYHA class improvement, or it improved more than 3 mils per kilo per minute in peak VO2 without improvement in NYHA class in mavacamten versus placebo. All the primary and secondary endpoints were significantly positive in the mavacamten group. Subsequent studies have shown that quality of life and biomarkers also trended grossly positive in the mavacamten group. As you can see the panel on the right, 36% patients had a large or very large improvement in Kansas City clinical summary score. So a lot of patients felt significantly better after 32 weeks on mavacamten. It also, in a sub-study, had a favorable impact on cardiac structure, including reducing LV mass index, left atrial volume index, as well as wall thickness. So downstream positive impact on the structure of the heart. In long-term extension studies, it has shown that the positive impact on the gradient, both resting and provocation, has been persistent. The improvement in NYHA class has also been persistent without any significant worsening of ejection fraction. Again, you can manage patients in your outpatient setting, and the clinical read in the core lab as well as at your site read, they were not any significantly different. So this is showing a strategy of standard clinical practice to be feasible. That brings us to VALOR trial, in which 93% patients were in NYHA class 3. This sought to determine if you add mavacamten to maximally tolerated medical therapy in severely symptomatic obstructive HCM patients, would they sufficiently improve to a point where they no longer met criteria for septal reduction therapy at 16 weeks? So this was double-blind placebo-controlled study, various doses of mavacamten versus placebo. Important thing is all the management was done by clinical assessment plus echo and stress echo evaluation at periodic times, with the endpoint adjudication happening at 16 weeks. The titration was done using core lab assessments. What did it show? The composite primary endpoint of decision to proceed with SRT or guideline eligibility. At baseline, 100% patients met criteria for SRT, but after only 16 weeks, mavacamten patients, 82%, no longer met criteria for SRT according to guidelines. And that difference was grossly positive compared to placebo. At week 16, every patient was offered a chance to go for SRT. 95% chose to continue in the long-term extension. You'll be hearing the results of the next phase of 32 weeks at AHA in 2022. What did the secondary endpoint show? Resting gradient, Valsalva gradient improved, biomarkers improved, Kansas City summary score improved. 63% patients in mavacamten had at least one class improvement in NYHA, 27% had a two-class improvement in NYHA functional class. There is a second drug being developed. It is currently starting phase 3 trial. The phase 2 trial results of this drug, aficamten, are similar to mavacamten, showing a reduction in outflow tract gradient without a significant impact in ejection fraction, and also similar impact on the NYHA functional performance. So more data awaited. These new therapies are obviously going to bring new logistic scenarios, but we have to assume long-term safety and efficacy. How often are you going to monitor ejection fraction? Who monitors them? Who dispenses these medications? Centers of excellence, primary cardiologist, somebody else. What is going to be the cost to society of long-term medical therapy versus one-time cost of surgery? What about the non-obstructive HCM patients? The ejection fraction story is what FDA is concerned about, obviously, and so they have approved the drug under the risk evaluation and mitigation, or the REMS strategy. So you can prescribe the drug, but you have to periodically, monthly monitor the ejection fraction for the first few months and then go periodically. Having said that, what I'm going to show is both Explorer and VALOR trials. The amount of ejection fraction drop was not significant, certainly not clinically meaningful. And as I alluded to, Maverick was a phase 2 study, non-obstructive HCM, and we are in the planning phases of a pivotal phase 3 study for non-obstructive HCM using mavacamten. So look out for that announcement. What are the potential future role of precision medication in obstructive? Can we take it upstream and treat asymptomatic or early symptomatic patients? Can we use them as first-line therapies, or delay or eliminate the need for invasive therapies? Advanced disease, how long can we treat these patients? What about patients that are high-risk surgical individuals? Can we modify disease? Can we delay progression to end-stage disease? All these questions have to be answered, including the survival benefit and cost effectiveness. To recap, medical treatment cannot be worse than the disease. We have to be careful about over-medicating. The standard therapy has many side effects, including anticholinergic effects, erectile dysfunction. We limit physical activity causing deconditioning, obesity. Use of generic drugs that are not as effective is also a problem in modern world. So sometimes what ends up happening is we go to shared decision-making about when enough is enough with medical therapy, and when do we move on to SRT as the next best option. So, case for an earlier operation. This is in experienced centers like the Cleveland Clinic. This is our data on almost 2,300 patients waiting for class 1 indication was associated with far worse outcomes versus an earlier operation, similar to the prior talk where the discussion about aortic stenosis surgery is moving upstream. So what we have shown is earlier operation in an experienced center is better. In an experienced center, doing a myectomy or myectomy plus concomitant mitral procedure is not associated with an outcomes penalty. These are the guidelines. SRT should be performed by experienced folks in drug refractory symptoms with outflow tract obstruction. Fix everything that needs to be fixed. If you cannot do an septal myectomy, then consider doing alcohol septal ablation. Currently, it says harm to do myectomy in asymptomatic individuals, and you should not do a mitral valve replacement if you can consider myectomy as an option. Class 2B indication is hinting towards earlier operation in the setting of other potential risk factors like AFib or pulmonary hypertension or poor functional capacity. Septal reduction therapy, as one can imagine, is not going to be a one-size-fits-all. If you have a standard thick wall HCM, you do a standard myectomy. If you do not have thick walls, you get creative and consider fixing the mitral valve or the papillary muscle. But bottom line is you need an experienced center with an experienced surgical team to provide these kind of stellar results. If you don't have an experienced center, then your outcomes are not good. So this is data published a few years ago. If you are at an experienced center, your risk of mortality is less than 0.5%. If you're in a low volume center, 1 in 6 patients will die from a myectomy. That's not good. So that's why I think we need to increase the size of the tent to offer more treatment alternatives like cardiac myosin inhibitors. What is the spectrum? So now the business part of obstructive HCM management. Surgery and alcohol ablation are typically reserved for the rightward part of the spectrum. What options do we have for the leftward part of this triangle? Not too many, so which is where we seem to think the precision medicine drugs like cardiac myosin inhibitors will potentially help. In my opinion, we should not be debating about patients needing which type of 2,500 invasive procedures. I think we should be focusing on improving the diagnosis in the remaining 600,000 patients. We should be thinking about how we develop optimal precision medical therapies for the almost 700,000 patients who do not undergo invasive procedure. And this, my friends, I'm only talking about the USA. What about the rest of the world? The MBA in me tells you and everybody is expanding the number of lives touched is a much better growth strategy for our society than trying to parse out a small sliver of the pie, fighting between myectomy versus drug therapy. The patient advocate in me reminds me that there is a tremendous opportunity to try and do more for our patients, improve the diagnosis, and evolve in our thinking in terms of therapies. Sudden cardiac death risk stratification is an important element. It is a complicated element, but every HCM patient needs to be screened. And if your risk in American criteria, if you have more than one risk factor, you place an ICD. According to the ESC criteria, if you have more than 6% risk, you place an ICD. And this is the flow chart of the American criteria according to current guidelines. Moving way upstream, early stage HCM. This is a recent study published, the VANISH trial, valsartan, was shown to reduce wall thickness, mass, volumes, LA volume, etc. So treating such patients, such genotype positive patients to prevent downstream development of overt disease might be a winning strategy down the road. More data to follow. Gene editing, CRISPR this, CRISPR that. Nowadays, we can CRISPR a lot of things. So time will tell whether this is an effective strategy, therapeutic avenue in hypertrophic cardiomyopathy. So to conclude, the future is absolutely bright in HCM. I think precision medicine is going to add an additional option in the fight towards a normal life. I am very humble about my opinion. It is not about my pill is better than your procedure. It never should be this versus that. It should always be this plus minus that. It is what we can do to make the best quality of life for your patients, because after all, it is patients first. You know, to quote Albert Einstein, imagination is more important than knowledge because that stimulates progress, giving birth to evolution. Imagination is the true factor in scientific research. I'll end here and be happy to answer any questions. Thank you for the invitation.
Thank you very much for excellent comprehensive review of HOCM and therapies that we have for it, and including the need to be precise and to deliver precision therapy. We have a panel available today for questions, so let's enable them. And I think Dr. Stock had a question she wanted to start with. Is that right, Evelyn?
Yes, thank you, Bill. I am so intrigued and at the same time very encouraged by all the presentations. I think everybody has given us both a understanding of these diseases as well as there is hope. So I want to ask Dr. Southard, when he sees patients coming into his clinic with, significant hypertrophy and possibly, moderate aortic stenosis, what is your approach to these patients and the therapies? How do you view these? And how do you combine like the precision part with the overall risk factors?
No, I think that's a great question. It's something that we deal with specifically in our patients who have been sent for, transcatheter aortic valve replacement. There's a few patients that we follow that have a combination of both hypertrophic cardiomyopathy and severe aortic valve stenosis. And we clearly put those patients not only through an echo, but an MRI and then cath lab studies to try and determine how much of this is related to hypertrophic cardiomyopathy, how much is aortic stenosis. If we alleviate the aortic stenosis, the obstruction there, will we worsen the outflow tract obstruction and make these patients worse rather than better? So we try and parse them both out. If patients need surgery for both myomectomy and valve, we could do both, or alcohol septal ablation first to eliminate the septal variants, the septal hypertrophy patients, and then replace their valve after. But I think you need to be very cautious about just assuming everyone sent to you has aortic valve stenosis because they don't. So we, I think, also like the Cleveland Clinic, mandate repeat imaging at our facility. We want to see it ourselves with our folks so we can try and delineate who we can help and certainly try and figure out who might have some of these alternative diagnoses not related to aortic stenosis.
The other point I'm going to add to close that loop is another bad actor, especially in the elderly aortic stenosis patients that is rapidly emerging, is the business of cardiac amyloidosis. And now with the advent of the technetium pyrophosphate scan, it is pretty much becoming routine for patients to be screened for amyloidosis. And we are unpleasantly surprised quite often nowadays when that pops up.
Fantastic. So we are lucky to have Dr. Ted Abraham with us today. Ted is the director of our Echo Lab, and certainly, we were very lucky to get him from Johns Hopkins, where he started the Center for Excellence in Hypertrophic Cardiomyopathy and is the director of our Echo Lab and a co-director of the Center for Hypertrophic Cardiomyopathy. Ted is well known to Dr. Desai. And I just want your perspective, Ted. And yes, tell us about the hypertrophic cardiomyopathy at Center at UCSF. And
Thanks,
maybe you have
Evelyn.
some questions for our speakers.
Sure. No, thank you, Evelyn. And it's wonderful to see Evelyn. And I know we'll be seeing him this weekend, maybe even before the weekend, Millen, and safe travels to you. Enjoyed your talk as always. And I think we'll hear more from you on Friday. But quick question on just the Camzyos. Are you experiencing any resource crunch, or are you having to upsize your resources to manage Camzyos, both from getting people onboarded and patient enrollment in Camzyos through the REMS and after that? Is the volume enough that you're not seeing a huge impact on your practice?
So thanks for that question. I think, given the requirements of I look at this brand new therapy as being a first-time parent. All of us that have been first-time parents, you are always extra careful with your first child, making sure, all the fancy car seats and etc. So the REMS program is just that. And yes, they have mandated this REMS program, and that does add a layer of more work and more upfront work, more scheduling work, and more follow-up. So this is at least the resource utilization is not going away. And yes, I think most large practices, it gets pretty unwieldy after the first few patients. So you do need support staff, a well-trained APP and or a nurse practice coordinator. I think, people are doing different things in their different practices, but I think, if I strongly believe in the principle of working at the top of everybody's license. So having the right team around you is going to be important in managing. Anyway, the disease is fairly complicated. The patients are fairly savvy nowadays, especially in hypertrophic cardiomyopathy, that most centers of excellence, like yours, like ours, we need a team, not just doctors going in. You need the expert sonographer, you need the MRI people, you need the genetics people, you need the nurses who will answer those 20 million questions that always arise. Realistically, it's the same thing in our TAVR practice, in our MitraClip practice. You name it. I think everything is becoming very sophisticated, where the most people love to talk about shared decision making, but shared decision making is not an easy ball game. That is a lot of conversation over a lot of time, and we need the rightly trained people to help us deliver that level of experience and care. So yes, long-winded answer. Short answer is absolutely, it is a resource-heavy endeavor.
Oh, thanks, Milind.
Yeah.
That's been our experience as well.
Mm-hmm.
Thank you.
So we have a question from Dr. Yu. Dr. Yu, you want to?
Yes,
unmute yourself?
thank you. Really appreciate the speaker's wonderful talk. My question is for Dr. Souther. A couple of them. I'm a family physician with Fallon Medical Foundation, so I'm more on the primary care prevention end. I really was struck by your talk about patients with asymptomatic aortic stenosis with early interventions have better outcomes. Naturally, my question goes to is that to our extent, how do we identify the vast number of patients that potentially out there that we should check for aortic stenosis? Because right now the approach is incidental, or patients have symptoms, we do the workup and yield them. So any thoughts you have that, I really appreciate it. Then I have an unrelated follow-up question.
Yeah, I'll answer that one quickly then. I mean, I think the hard part, you have the hardest part is identifying the first patients that require an echo for follow-up, and it requires keen auscultation, right? I try and tell at least our docs here, I want you to listen with the intent to hear something. Pretend there's a group of people around you. It's physical diagnosis. You know you're supposed to hear something, so you better listen with the intent to hear what everyone else is about to hear. Because a lot of times we walk into the exam room and when there's no diagnosis of AS or MR or HOCM on the chart, we do a cursory listen because we're trying to do 20 other things, especially as family practice or primary care. And the focus is not honed into listening for a valve lesion or valve murmur, which might be there. So I think the hardest part for you is early auscultation to pick up anything that you might hear and have a very low threshold for echocardiography. Any EKG you might get for pre-op work or anything that shows LVH, get that echocardiogram right away to see what's going on. And then I think early referral, anything you pick up on echo that's abnormal, even in a mild to moderate stage, get them referred over at an early time period so they can be treated appropriately and quickly.
Thank you. That's very helpful. My second question has to do with if you could share what's your trajectory about this technique to help with patients with bicuspid valves?
Yeah, and it's still a point of contention. We still have a lot of data in patients for the transcatheter valves that can be used in patients with a bicuspid aortic valve. I think what it comes down to is how old is the patient, what type of bicuspid valve they have, which is a whole different lecture. Not all bicuspid valves are the same, and they don't respond the same, and we don't get the same results from a transcatheter valve versus a surgical approach. So we can do transcatheter valves in a bicuspid valve, but we look at each patient individually. If they're younger, their valve is heavily calcified, they have a dilated aortic root. If they're low risk for surgery, I would much rather my 60-year-old patient have a surgical valve replacement early on and then allow us to do a transcatheter valve inside of that surgical valve later on than do a TAVR valve up front. So I think the bicuspid patients based on age, et cetera, I usually look at them as a surgical option first. And for some reason, they're not surgical patients. And we see what we can do from a transcatheter side of things.
Thank you very much.
One comment I will add. Nowadays, I think, especially in these 50s, 60s patients, we have to establish expectations that, if we do a SAVR right now, then we have to talk to the surgeons, make sure you put the largest size valve. If you need to do annular dilation or whatever, do it so that our interventional colleagues can do a valve-in-valve TAVR 10, 15 years from now. So almost pretty much always shared decision making that you are gonna it's probably a SAVR, TAVR, or TAVR. The word jumbling, the word mumbling jumbling is going to be important going forward because it's not just this or that. As I alluded, it's always this plus minus that.
So Dr. Sky.
Okay.
Yeah.
So I'm an Air Force cardiologist at Travis Air Force Base. I have a question for Dr. Desai. As you may know, the Air Force has tried multiple ways to screen our population for things like hypertrophic cardiomyopathy and bicuspid valve. And we settled on that echo was a little bit too much for the yield about 15 years ago, and we now do regular ECGs. My question for you is, in an attempt to identify hypertrophic cardiomyopathy in the general population, as you showed in that graph, as to the undiagnosed out there, if you could pick anything right now, what would you pick for screening in the asymptomatic general population? And then a related question is, are you an advocate for the athletic screening with ECGs for everybody as well?
So I'll answer the second question first. No, I'm not an advocate for screening everybody with an ECG because, look, our society is not homogeneous. About 20%, give or take, the number can vary depending on what series it is. The standard criteria for LVH detection will overcall a lot of disease in African American population. women, we know it is already not very, ECG is not very good in women. So with that in mind, imagine the potent bad combination of false positives and undereducated physicians, or not so confident physicians in in recognizing the disease. You are gonna create a scenario where a lot of anxious folks whose careers may be on the line because of an overdiagnosis of ECG. So ECG screening has never really taken off, either in athletes or in the military, and I do not endorse that. You ask me, I'm gonna say, if I had all the resources in the world, and if I were to screen somebody, I would use well-trained sonographer to do echocardiography for coming to this diagnosis. Now, having said that, Ted is on the line, so hopefully he can chime in. With the emergence of point-of-care ultrasound, okay, so those handheld ultrasound devices, I think we are entering into a new era of diagnostic capabilities. In fact, just recently at European Society of Cardiology in Barcelona, there were at least 2 papers published, large studies. One of them using artificial intelligence, not point of care, but using standard AI out of Australia, where they showed that it was excellent in detecting aortic stenosis. So that can be tweaked to detect bicuspid valve. Another study actually came out of Cedars-Sinai in California, where AI was found to be better than sonographers in assessing LV function, et cetera. So the world is moving towards such rapid assessments, automatic assessments, and quicker, more limited point of care assessments. And I'm assuming, my hope and expectation is that the cost is going to get better. So if I were to set my bank up, I'd go with some form of imaging rather than just blind ECG. Of course, we still have to train a broad swath of diagnosticians to do a better job of diagnosis.
I appreciate that answer. We have spent many years with our ECG screening, and unfortunately, there are many disqualified pilots that probably should have never been disqualified. As we learned more about it. So I very much appreciate your answer. Thanks.
Agree, Milind. We, even in the Hopkins database, 20% of people with pretty severe HCM had completely normal looking ECG. So I would never endorse a ECG only approach, and I completely endorse and agree with you on if it becomes imaging, it needs to be inexpensive and probably AI enabled, so you can do it for pennies on the dollar in as far as both performing and assessing thousands. And I think those are happening. We're in fact working with a platform that it looks like a hockey puck that you can just put on someone's chest and get an ultrasound, get a quick parasternal long. So if that comes to fruition, maybe we can talk to Dr. Sky about using it, trying it out on the Air Force folks. We did something similar in Maryland with the Naval Hospital there. So yeah, more to come. And certainly for HCM, I think, as Dr. Desai said, imaging would be key.
I have a question. Will we always be focusing on the phenotype, looking at the imaging, or is there a possibility that in the future, 10 years from now or more, that we would have enough genetic information that we could potentially get it from a blood test or from a biomarker that would be available?
I assume this is a question for me.
Yes.
So what is the current state of affairs right now? Is if you take 100 patients that look phenotypically like HCM, different, not from the same family, but 100 different patients, the genetic yield is, in the best case scenario, about 40%. which means there are 60% other patients that, clinical
Don't
doctors
fit.
like me still have to figure out a strategy of how to manage. Now, having said that, the science of genetics is rapidly evolving. And so just because you are negative today doesn't mean 5 years from now we have not identified the mutation in identified the mutation. So routinely what I tell my patients is as follows. If you are gene negative today, let's repeat things in 4 to 5 years because something may have emerged. If you are variant of unknown significance today, let's revisit that in a few years because you never know what is unknown significance today. Tomorrow, it may assume significance. So I think, today, what I tell my patients, it doesn't really matter. If you have HCM, we're going to treat you with what we know. The fact that you are genetically negative today, so what? Where I find it very useful is if you are gene positive as an index case, and then you do cascade testing. More importantly, the ones that are negative, they are done. Their family and their downstream generations are done. My utility for HCM or for any inherited cardiac disease is in that context. I mean, yes, people in the past have tried to look at, one mutation is more pathogenic than the other. While it may pan out in the future, it has not yet panned out in the past. So, I think we still need to treat the entire, if you have HCM, we're going to treat you. It doesn't really matter what, we are not going to discriminate you because you are genetic positive or genetic negative.
We also had a question in the Q&A related to insurance coverage. If a referral is made to a center of excellence, what insurance companies allow that coverage to continue at the center of excellence, or do they restrict it? Have you seen problems with getting insurance for some of the procedures and therapies that you want to use?
Yeah, of course. I mean, God created insurance companies for the sole purpose of creating barriers. So no, they are not going to go away without a fight. But, the important thing is guidelines do state that it is better to get this kind of care at an experienced center. Data have shown that if you don't go to an experienced center, your procedural outcomes are far worse. So basically, that conversation, if had with the insurance company, more often than not, they come around. A lot of times what ends up happening, though, honestly, is the definition of an experienced center that lies in the eyes of the beholder. I'd be very honest, if your surgeon does 10 myectomies a year or 10 myectomies every 2 years, but you have all the other bells and whistles of calling it an experienced center, I'm not entirely sure I'd send my family member to that surgeon for a myectomy. I would seek out a much higher volume center. So, and the insurance companies will argue back, but that's where you you have to have a good counter argument. Now, having said, look, I am spoiled by working in a place which attracts patients from all over the world, and very often that makes the conversation easier. But I think it's more than making the conversation easy. It is making the right conversation backed by the right amount of data. So often, if the insurance company, they still want to be jerks, then so be it. But for the most part, we find that it eventually works out.
So Dr. Southard, similar to that, is there a number that you would pick for TAVRs at a hospital where you would feel comfortable referring a patient there, a minimum number per year?
I think this question has bearing, so I have to be very cautious in the way I answer it too. But I think it's something that's actively being looked at, right? As we expand the number of centers that are doing transcatheter valves in the US to over 840, we look back at the centers that are doing 20 a year, 24 a year, one every 2 weeks. Is that enough? Is 25 a year enough for, and is that the same person doing it? Or do you have multiple people sharing those 25? So it's hard to figure out that number, but you know, since we're lucky enough to do these things multiple days a week, we still learn, right? We're thousands and thousands into this game, and you're still learning the nuances of placing transcatheter valves. So I'm not sure what the minimal number is, but you've got to be doing this on a weekly basis, I think, with a number of aortic stenosis patients out there to stay good at it, because doing it wrong will end up hurting your patient. And the same goes for myectomy, right? There are much fewer competent surgeons doing myectomy in the United States and the world than are doing TAVR. It's much more complex, and the number of centers that can do it well are very few. But that the burden then of the disease is on those very few highly qualified centers or surgeons. So I'm not sure what the number is for TAVR, but I think it's more than 25, which has been thrown out there. I think if you're doing 50 a year as a single operator, that's at least pretty good to keep your program going.
Yeah, we have similar questions related to just regular coronary artery cabbage graft surgery, et cetera. But yet in California, we have a large number of hospitals that have low volume cardiac surgery at less than one a week. And our concern is, how do you keep a team totally trained in performing exceptional surgery when you might miss a week or two and not see a patient? So that's a concern. And we do have numbers for PCI that we want to see 50 per year averaged over 2 years as a minimum for the SCI ACC FAHA guidelines for PCI. So we may be getting into those numbers as well. Do we have any other questions from our panel? I know we're getting just past 9 o'clock. So for our panel that we assembled, Eveline, do we have any other questions that the panel would like to ask or add to?
So I would like to ask of the panel of the speakers how they see these new therapies that are very promising. How do we enhance our health team's outcomes? Do they see that LVH or some form should be added to our risk score estimates for, cardiovascular disease risk? Right now, LVH is only in the stroke guidelines, but not in the general cardiovascular disease outcomes. If you had one thing to advise the insurance companies, the Center of Disease Control, to improve outcomes, what would you add to these risk scores as an estimate for the general population that might have a bigger impact? We can start with Dr. Desai. Is there anything you would pick?
Well,
add?
I mean, yeah, look, LVH, yeah, I mean, with the aging of the population, you're going to have more comorbidities, more hypertension, et cetera. So LVH could be one of the downstream things. I mean, to me, if you ask me, BMI, obesity, some of the factors that, man-made comorbidities are something that, in my simple mind, it would make more sense to have that as a bona fide risk factor if it is not already, because, that is what drives a lot of other scenarios. I mean, but that's just me.
But Dr. Sutter,
No, I agree. And we're at an area where, obesity within the United States is actually, a huge risk factor for all these other comorbid conditions. So it's a big deal. I think if we were to identify left ventricular hypertrophy in patients, finding out the etiology is very important because it's usually linked to something not related to an athlete's heart. It's linked to something else that requires therapy that could affect their outcomes and longevity. So once identified, probably deserves more of a workup, usually associated with pathology and not a benign condition. So,
and hypertension is the most, not AS or HCM. I think it's in the broad spectrum of life, hypertension is a much bigger deal. And I think that's why I went upstream to bring out obesity, because one of the biggest risk factors for hypertension is a bad lifestyle.
So last question, Dr. Desai, with your MBA, does that mean if we go upstream on myosin inhibitors, is that cost something that we can afford with our current situation of 18% of the GDP going for the healthcare dollars?
Well, look, I think the business of drug cost pricing is a very uniquely American thing. I will, in the context of HCM specifically, if we know that having obstructive HCM is associated with adverse events, number one, is associated with long-term bad outcomes. Number two, we know that there are not enough centers that are able to afford. So first step we have to realize is having HCM bad versus not having HCM? What is worse? Having HCM is worse. Then obstruction, is it worse versus not worse? The obstruction is worse. Then are there centers that can relieve effectively obstruction? Do we have therapies that effectively relieve obstruction? If the answer is, then that's how you navigate yourself into what appropriate patients will be benefiting from which therapy. Why just talk about cardiac myosin inhibitors? Wouldn't it be nice if we can do some gene therapy down the road that can fix the structural downstream impact of HCM? Same way, if we are able to show. So what is the value if you are able to show that a precision therapy given to a young 20-something-year-old can alter the trajectory of disease so that they do not develop the downstream LVH and the fibrosis and the obstruction, and it is associated with improved longevity? What is the value of that? I don't know. Yes, is there value to that? And those are the things we just don't simply have the answers right now. But this is a step in the right direction. The first computer system that sent the man to the moon, I don't think cost $1,200, right? It costs an awful lot more than that. But the iPhone that we have, which is more powerful than what sent the man on the moon, doesn't cost $1,000 anymore. So, cost changes. The cost changes. The cost should not be an impedance for progress. That's the way I look at it.
Thank you very much. Well, we're past our time of 9 o'clock here on the East Coast and 6 o'clock on the West Coast. So I want to thank our speakers for their presentation. I want to remind everyone that our next program with Dr. Gulati and Dr. Marin and Dr. Budoff will also feature the Danish investigator from the Dan Kavis trial, recently released and discussed at the European Society meeting on coronary calcium and its effects. And Dr. Gulati will talk about her effort in leading the group to develop chest pain guidelines, which is looking at literally a symptom, not necessarily a clinical disease, but it's a symptom of chest pain and how to approach that, especially helpful for those of us working in the emergency room and some of our primary care practitioners. So we definitely want to thank Dr. Desai and Dr. Southard for their excellent, comprehensive presentations today. We will look forward to seeing future work and success from both of you. And we want to thank everyone for sticking with us, despite the fact that we're not able to prevent the Hurricane Ian from hitting Florida in the next few hours. We do feel prevention in healthcare is the way to go for the future. So thank you, everyone, and have a great evening.
Thank you for the invitation.
Thanks,
Have a nice-
everybody.
Good night.
It was great to meet you all.